Top Bed Talk.
Herod and I would like to invite all the speakers to come and sit on the comfy sofas. So, June Davis. June is an allied health professional advisor for Macmillan Cancer Support and is the co-chair of the Prehab for People with Cancer initiative, which is a collaboration between Macmillan, the Royal College of Anaesthetists and the NIHR.
Next, Mike Grocott. He is one of the co-organizers of this conference. I feel very proud of this conference. Last year we had a hotel in Eindhoven and now we have the British Museum completely filled. He is in Wade, Vice President of the Royal College. And it's easy for me to introduce him because it doesn't need introduction as a professor of anesthesiology at Southampton. So please, Mike.
Professor Franco Carli, otherwise known as the father of prehabilitation. Franco is Professor of Anesthesia at McGill University in Montreal. He has been one of the lead organising committee with us and with Herod for this conference. And he is also the first honorary life member of the International Prehabilitation Society. So can I welcome up Professor Franco Carli, please? So basically, the way it'll work is we'll pick the top questions that you've liked and just work through and put them to the panel, or specifically if you've asked a specific person. So just to start off, there's a clear favourite here, which is from Anon. And the question is there any good evidence for the use of wearable tech in prehabilitation?
I'm not aware of any good evidence, but I am aware of quite a lot of people who are working on it. So basic answer, no. But expanding the question out slightly, one of the things we know is if you can prehabilitate people by bringing them to hospital and supporting them closely and supervising them, and that's pretty straightforward, or you can ask them to do something at home, and that seems to be almost universally a failure, or you can go for the community route. And maybe the bit we're missing at home is a kind of ongoing communication, so wearables, monitoring, regular feedback. My bias would be it's quite likely to be quite effective, but I don't have any data at the moment.
Addition there from...
Again, a lot of work going on, but evidence is, same as Mike.
Franco?
Yeah, I think one of the problems is that, in my view, is that we looked at some wearable. There are issues that there are batteries issues. The patients have to, especially elderly patients, they don't know how to charge the battery. There are practical issues that, unfortunately, but I see the future. They're expensive too. A sophisticated one will cost approximately $1,000, a good wearable. So if you have 10 patients, it costs a fortune, and then you have to come back and so on. So I think it's going to happen. There's the future there. I think we are not sophisticated enough in terms of technology to capture the data, what exactly they do, in my view, personally. And I think, even the wearable, you probably know, circulation. There was a paper about 2 years ago about patients, especially with atrial fibrillation and so on, wearable, they were not accurate. So I think we have to be very careful, but definitely I will see very much. It's excellent. Technology, we have to use it, and I promote entirely all studies on that. If you're really able to do it, do it.
I want to pick a question that is not on the list here, but I saw before, and that's probably one of the most important questions. And the question is actually for all of you, but I'm going to direct it to June. How come, if the evidence is almost there, that prehabilitation is not included in every pathway yet?
Great question.
I just made it up.
It's a really good question. And I think, to be fair, I think it's not been thought about, and it's not had the profile it has required in oncology. That's not to say that there's some really great work going on, but there is mixed views across the multi-professional team about what should be done. And I think the publication of the guidance, that's one of the reasons that we wanted to do this work, was to sort of push out and push the boundaries a bit and say, look, why should we not exclude this community? And it's a large and growing community. And particularly as we've got extending survival rates, which is a really good news story. Therefore, we need to do more in this space. So I think it feels when you start talking about it, why haven't we done this 20, 30, 40 years ago? And I think that's been, a lot of it has been about myths around, a lot of it's around waiting times, a lot of it's around the time we've got to do things, but we're trying to dispel that. Engagement with our commissioning and arm's length body colleagues is making quite a significant difference, and there's some colleagues in the room that are demonstrating that to NHS England and others, that actually the benefits outweigh the risks. And mandating it in the pathway for me is, and I'm sure for others, is really, really crucial that we do that. So in the guidance we have illustrated the cancer pathway and the difference with prehabilitation included. So I think it's just not hit people's radar as soon as other non-cancer surgery has in the past, because this world has been around for a long time. So it's a good question.
And Franco, do you see a change now? Is there something revolving?
Well, I'm not, I hope there are oncologists here. I would like to see if there's any oncologists. I think we need the oncologist on understanding that chemotherapy is not the only solution to this. And I really is a multidisciplinary. We need a radio-oncologist talking about cancer. We need a surgical oncologist as well. I think it's going to happen. I think we are at the beginning of all this. I mean, you're talking about they're not part of the program. Actually exists already in oncology. They give leaflets. There is an education. But when you actually go to the next step, which is this much more patients' participation, that's what we don't have. Or we have limited and so on.
All right, thank you both.
Okay, so I'm going to be slightly more conventional. Herod went a bit off-piste. I'm going back to the list. So I don't know if the person's called Sheffield or they're from Sheffield, but I'm going to ask the top question, which is to you, Mike. I would like to think my patients see themselves as a partner, but many choose to remain passive participants. How do we improve engagement?
So I think that's okay. If a patient chooses to would prefer that relationship with their healthcare professional, that's completely fine. But I think what we've tended to in the past is impose that relationship. So I think part of it early on is defining what the interaction is. Some patients come incredibly well informed. They've used Dr. Google, they've spoken to friends, they know all about these things, and they want to be a partner in the whole business. Designing the sort of intervention they do, how it fits into their life. Others, I think, are more comfortable with a traditional paternalistic approach, and some of that's about age, some of it's about social deprivation, that kind of thing, but some of it's just personal. So I think the relationship is what the patient wants. So if they want a paternalistic relationship, fine, but we need to be adaptable to those who do not want to be told but would like to partner. Any
further comments from...
I just want to say that, you have to accept that if you look at any studies, just look in the studies, you almost have 50% you patient don't want to, they refuse. Just simple as that, okay? But then when you go, this is a different story because it's a study, but if you go into actually referral, I think it's crucial to have the community. Who is a referral? I'm an anesthesiologist, so therefore I run the prehabilitation clinic. But I think if I have a surgeon who actually insists, and that's what we see from us. We saw that when we started with surgeon, now we have 5, 6, 7 surgeons who are actually referring to us all the patients, with the screening and so on. So I think it's there. It's going to come back. You have to accept that some patient will say, I don't want to know anything about it. I think you have to accept it.
All right, I'm going to pick the question up on the top, June. What are the benefits that can be seen in as little as 2 weeks of rehabilitation? And what are the best indicators to see whether it works?
Okay. Yeah.
Detailed question.
Yeah, this is a tough question. I can do the first bit. I guess it depends on what people's baseline is. So what an person's baseline is at start. And clearly people come from different, fitness levels, nutritional status, etc. So we would see changes if interventions are such that they would improve physical fitness, they would improve their nutrition status. It would depend on where they were at, and it depends on their psychological well-being at the point of starting. There are different potential indicators the guidance, we are suggesting that there needs to be much more robust framework around outcomes, indicators, effectiveness, and all the rest of it. I don't know, Mike, if you want to add to that. Because it's the most tangible thing in terms of measuring is their physical fitness.
If you're doing, some of the programs are responsive, so as the patient gets fitter, you want the training stimulus to get harder, and therefore they have repeated tests through the program, and you clearly see, particularly in the least fit patients, that the change from 0 to 2 weeks is significant. Yeah. It's not all that it can be achieved by a long chalk, but you're starting to see benefits right early on, and they are sustained. And to a degree, they tail off. You can't keep on adding 5% a week, for example. So there's something of a curve like that over, I guess, 6, 8, 10 weeks. But I think we're still defining exactly what that curve looks like, and it'll vary for different people.
Yeah. The question is interesting because,
it's a really important question.
For instance, in lung cancer, you will not accept a delay like in colorectal cancer. Correct. So we designed a protocol for lung cancer, but it's only with 6 or 7 training sessions instead of 12. So could we still expect a result then?
Yeah.
All right.
Absolutely.
Thank you.
And the treatment doesn't preclude the training. So obviously if you're on the table having an operation, tricky. But I mean, certainly those going through chemotherapy can continue training but at a lower frequency. And we and others have done studies like that.
Yeah.
All right.
Okay, there's a really nice question I like with somebody with a similar name to me, Jerry D, but I better go back to the top of the list. So I really like this next question. I think this is a really good one, and I'll put this to all the panel. With a strong push for prehabilitation, is there a risk that an individual patient may feel blamed for a poor outcome? How would you strike the right balance? So could that be a non-complier, perhaps? Or, I don't know, you could frame that different ways, I suppose.
So Jerry, I think one of the points there is about how we work with our patients, carers, and the families, because I think people need to have it explained, and there needs to be some clear expectations set out about the whole pathway. It's really difficult to just talk about this bit, and it goes back to what Franco said about just talking about prehab in isolation of the wider package of care that this person's got to think about and choose and all the rest of it. So I think we need to be really careful about what that looks like, because the outcome and the difference in the outcome will be dependent on many, many factors. So that has to be really clear, and it goes back to testing understanding with people throughout the process, because it's not, they will forget and their mind will go on to other things, we know that. So I really like Franco's diagram of how you test back what people have really understood about some of this. That would be my take.
I mean, it's a very thoughtful and important question.
Yeah,
I think the risk is there, so therefore we need to be sensitive to it in the communication, how we communicate what we're aiming for. And I guess to a degree it overlaps with some of the sort of rationing discussions about where a right and wrong judgment is being imposed on something. But I think what we could say, do the best that you can, and that's all you can do. That will achieve the best that can be achieved for you. It's a good question, and I don't have a really good answer.
Franco?
Yeah, it's actually quite interesting, because we had a few patients who actually said, thanks God I came to see you and you gave me that, and so on. Could have been worse, my outcome. And the family will tell you all about, which is quite important. So I think it depends very much on, as you said, the expectation, the explanation, and so on. But, the patients who feel engaged very much, I think appreciate that what you actually do, you do something that generally is not given, is not normally done it. So there is always something positive into this.
All right, we'll go to the next question then, and this is to Franco. Yeah. You set up a streamlined preoperative service, and it looks fantastic. But how would you advise the people to get started, and how do you take this journey, and who are the key people to get involved?
Come and visit us. It's very different. Everybody says, how do you do it? Well, it took me 7-8 years to actually do it. We started with one room and so on. So now what we have actually convinced the institution to actually recognize as a preoperative rehabilitation unit, but a clinic at the same level as the preoperative. This is for the surgical patient I'm talking about, okay? And I think that's where the interaction is very much with the internal medicine, geriatric medicine, and so on. But all the platform is one. The patient doesn't go, as I like very much the definition of Park, who would say Park was the guy from Veteran Administration, who actually the patient is ping-pong. That's what we actually do. Stop this nonsense. The physician has to come and see the patient. And that's what we try to establish. So if we know in advance, the geriatrician will be there, the nutritionist will be there, geriatrician will be there, and so on. So it's actually much more feasible from the patient's point of view, except, of course, some situation which will be difficult, MRI and so on. But in terms of consultation, if it's necessary, I think that's where. And also, we are physicians. We can actually do an assessment. That's what we are training for. And so this is very important to actually say. So how do you set it up? Right. I think the preoperative clinic is crucial. When we started the enhanced recovery 10 years ago and so on, we said clearly to the administration, to the surgeons, if there is no preoperative clinic run in this way, where you have a unit with the nurses, with a physician, an internist, or general GP, depends what you use in your institution, and anesthesiology, we're not going to start enhanced recovery. And now we say if there is no enhanced recovery, we don't do prehabilitation. That has to be clear, because as I said, there is a paradigm shift. So, and that's basically the essence of what you do. And I think you can establish, if you have a preoperative clinic, I think then anesthesiology should take the lead in prehabilitation. I mean, we are basically, we say we're talking about perioperative medicine, just let's show it and do it. So in this sense, this is how it happens. And then, of course, you create a team of, I start philanthropy. The hospital will not give me anything. Now they recognize they will give me something. And thanks God, with philanthropy, are able to have a kinesiologist, if you use kinesiology, physiotherapist, nutritionist, and then volunteers. You have plenty of people who come to you and say, can I help you being a psychosocial? Can I help you to do you will believe it, how patients realize how useful it is for their relatives. So I think you start like that. I call it the bottom-up. That's how we did it, bottom-up. And then you can have some situation where you actually start from the top. It's legislated. And that's the difference. Good luck. I think, it's true, because then you have a different standard. I think you have to really look at your situation, your area, your institution, your hospital, your clientele, and then work around that. But anyway, if you are coming to Montreal, it's a beautiful city, you see how it's done.
And if you can't afford to go to Montreal, there are a whole host of centres around the UK
That's
that
what
have
I
set
said.
things up.
Do here.
So I hope you got the answer that you were after, whoever asked that question.
Yeah.
So the next question is a really interesting one. When we review systematic reviews in this area, we see that there are a whole host of different outcome measures, which makes assimilation of the literature quite difficult. So this is actually directed to June to start with. What do you think would be the most important outcome for any new prehabilitation trial? Sorry to put you on the spot, but it wasn't me, actually.
No, that's fine, it's fine. I'm just thinking. I think it's a combination of, we have to demonstrate cost effectiveness and quality of care. And quality and cost have to be balanced. So I'm sitting slightly on the fence, but you need both. So there needs to be some quality outcomes as well as health economic outcomes for people to take notice.
Okay, any of the other? Franco? Mike?
I mean, the patient's always a very good measure. They're softer outcomes in terms of being clearly subjectively expressed and therefore harder to put into numbers and manipulate statistically. But patient satisfaction with the whole episode, not just the day after surgery, but maybe a year later, is a really big deal. If it worked for them, then we did the right thing.
It is a shame, however, that we have to talk about money and not about well-being for patients.
Correct.
Because whenever the other question was about funding, how do you fund a preoperative clinic? Well, we see the value of it. It's always about the money. I think one advice is to involve management at the beginning. Let's get at the top of the list. How do you get past selection bias in prehab trials? The ones that might need it most might not participate. Franco, you're an expert on that.
Well, this is the behavioral. What you do is behavioral, so I don't think you can control very much. It's not. This is one of the problems of prehabilitation that I found at the beginning. It's not a tablet. It's not that you can do placebo and so on. This is the difficult one. So there are so many factors which you have to take into account, and that's where probably the larger trials will actually help us to say something.
Because initially, when we started doing prehabilitation in a trial, it is you offer the patient to participate in the trial, and they could be lucky and get prehabilitation. And nowadays, it seems like if you invite them into the trial, they can get unlucky because they will not be prehabilitated. And that's a revolving thing, but you can avoid that. It's hard to get the true evidence.
Okay, so back to the top. Redesigning the perioperative pathway. I know where this one's going. Is there collaboration with the surgical profession to achieve this major goal?
So you can't do it without working as a multidisciplinary team. Certainly, team anaesthesia are not in a position to impose that. Our experience, and I think it's mirrored by a lot of other people's experiences, if you can work with a local enthusiast, a surgeon who is into perioperative care, prehabilitation maybe, and get them to work with you on, how can we get to patients earlier, how can we involve them in thinking about prehab or shared decision making or whatever, and get that to work. The nature of surgeons is they tend to be a little bit jealous of other surgeons who have something they haven't got. Is that right? Is that true? So you can get one pathway to work in a centre. You can typically then get the other surgeons looking over going, I'd quite like a little bit of that, please. And that seems to be effective. I think it would be very, very hard to try and sort of sweeping change across the board in an institution, but starting small, the bottom-up approach. Start small, work hard, get it to work, and then allow the success to speak for itself.
Well, I have to truly compliment you here in the UK and in Canada, is that anesthesiologists are so much involved in perioperative care. Just across the channel, it's hard to get anesthesiologists involved, and it's actually the knife-holding specialists that not only care but take the initiative to get this revolution going.
Yeah, ultimately, it doesn't matter who does it, as long as it gets done.
But still, you have more knowledge about cardiopulmonary issues than I do. Let me do other work. There's a final question from the top. In a usually sedentary patient, can this patient do high-intensity training safely? In a usually senior sedentary person, is it safe?
Yes, and they do. It's always an answer with two aspects. The instantaneous risk of dying whilst exercise is higher than whilst sitting here at rest. But the aggregate benefit of having exercised far exceeds that instantaneous risk. So there is a very modest risk of training, and probably, although I'm not sure the data supports it, high-intensity training is going to be more risky than moderate-intensity training, although it might be more beneficial. But in aggregate, over the course of your subsequent life, it's highly likely to be overwhelmingly beneficial.
And then do we need triage to select these patients that can do so safely? Franco, I see you...
I think you screen them. I think the surgeon will send you anyone, definitely, because they're all excited, and now they send you everyone. And then you need to screen, and then you decide which one you want to do some high intensity. But you're right, you can do high intensity to any patients. I mean, of course, according to some... with a limit, but otherwise I think that your screening is essential.
There's some very rare specific medical contraindications, but for excluding those issues, But the patients who are least fit and most comorbid might be the ones that you choose to do the specialist intervention and do it, initiate the whole thing in hospital, get them used to it, and have that as your safety buffer, and then progress into the community. And
they might have to have cardiac issues solved before they start doing anything.
So just before I thank our speakers for what was an excellent session, just a couple of other sort of announcements. It's also important that this day one and the meeting has been held in association with the Perioperative Exercise Testing and Training Society. And this is an international society which is available to everybody here. If you want to know more about the society, the AGM will be held in here at 1:15 today, so please feel welcome to attend. And we have our President, Chairperson, Danny, at the front here, who will be hosting that and telling you all about it. So please feel free to attend that. So I'd just like to finish by thanking all of our speakers. It's been a fascinating session to get kicked off. So if we can give them a big hand, and if I can encourage everybody to be back for 11 o'clock. Thank you very much.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.